Noon. Welcome to Health and Government Operations Subcommittee. This is a little different today. We are starting with voting, and then we're going to do bill hearings at 2 o'clock. So thank you for the flexibility, and thank you, members, for the hard work that you're doing. I have a friend that came to visit me before this, and she gave me this, which is a little coin for me to keep for the next 40 days. And you know what the coin says? It says, God, grant me the serenity to accept the things I cannot change, courage to change the things I can, and wisdom to know the difference, okay? Let's go at it. So if your bill is withdrawn, it's not going to come alive. Let's go. So we have 4 bills that are withdrawn. Is there a motion? It's been moved in second. It's okay. Are you guys okay? Okay. All right. And someone moved okay. So it's been moved in second. Are there any questions or concern? Seeing none, all those in favor say aye. Aye. Any objection, opposition? Seeing none, they're withdrawn. Let's move on. 1 second, guys. House Bill 56. Delegate Charkoudian, Procurement, State Department of Education, Control Authority, Local Food Purchasing. It came out favorable with amendment. It is Lindsay and Kerr. Lindsay.
As introduced, this bill would have given the Maryland State Department of Education the authority to engage in or control procurement of food by local school systems without the approval of any other primary procurement unit. It also would have required MSD in consultation with the Department of Agriculture to establish a platform to facilitate procurement of food by local school systems, exempts procurements from MSD for the purpose of master contracts from oversight by the Board of Public Works, and will require MSD to report annually on those procurements. The amendments that begin on page 1 in your packet, adopted in subcommittee, require MSDE when funding is available and in coordination with DGS, the Department of Agriculture, and any other relevant unit of state government to establish a program to engage in the procurement of certain local food for local school systems, and specify that the program shall give preference to providers qualifying as certified local farms or certified Chesapeake invasive species providers. Retain the December 1st annual report, but requires that report to be on the total number and dollar value of procurement contracts, including the number of contracts that are with the certified local farms or certified Chesapeake invasive species providers. The amendments authorize DGS and require the Department of Agriculture to work with MSD to procure local food for local school systems under the bill. And the amendments increase the price preference adopted by BPW for the purchase of locally grown food by state schools and facilities from not to exceed 5% to not to exceed 10%. Alter the definition of locally grown food for the purpose of that preference to food grown at a certified local farm, and authorizes BPW regulations to limit competition to certified local farms.
Delegate Hill, okay? For that reason, I'm going to make you the floor leader. Just kidding. I put my pen down. Delegate Kerr.
Well, thank you, Madam Chair. We discussed the amendments in subcommittee. There were no issues or concerns. We adopted the amendments and recommend the bill to the full committee unanimously. I move the amendments.
The amendments have been moved and second. Any questions or discussions on the amendments? Seeing none, all those in favor say aye. Aye. Any opposition? Seeing none on the bill? Second. Bill has been moved and second. Is there any question or discussion? Seeing none, all those in favor say aye. Aye. Any opposition? Seeing none, the bill passes. Who does not want to be on the bill? Delegate Shalega. All right. And Riley. And who? Riley. And Riley. Okay. All right. So let's move on to House Bill 268. Delegate Charkoudian, Hospitals, Financial Assistance and Collection of Debts Policies. Favorable with amendment, Aaron and Kerr.
The bill alters hospital financial assistance and collection of debt policies, including requiring a hospital to reduce a patient's out-of-pocket expenses for medically necessary care by a specified percentage based on the patient's family income. The bill prohibits a hospital from filing a civil action to collect debt against a patient under specified circumstances and increases the number of days from 180 to 240 before interest payments on medical debt may be assessed or a hospital is authorized to take civil action to collect debt. The bill alters notice requirements for hospital financial assistance policies and alters the monthly payment amount for an income-based payment plan for medical debt. There are amendments on page 9 of your packet that were adopted in Government Operations and Health Facilities Subcommittee. The amendments provide that a contract, including a contract under seal, that is related to an obligation of a consumer to pay consumer debt that arises from hospital services between a consumer and a hospital is not subject to a 12-year statute of limitations that's provided under current law on certain actions. It requires a hospital to obtain documentation ensuring that a patient acknowledges the patient's receipt of notice of the hospital's financial assistance policy before discharging the patient and removes the ability of a hospital to include a professional fee under its debt collection policy.
Delegate Kerr.
The Maryland Hospital Association came to the subcommittee to express their agreement and acceptance of the amendments. We adopted the amendments and unanimously moved the amended bill to the full committee. I move the amendments.
The amendments have been moved in second. Any questions, discussion on the amendments? Vice Chair Collison.
Not on the amendments, but on.
Okay, so on the amendments, all those in favor say aye. Aye. Any opposition on the amendments? Oh, Delegate Kipke.
I have a question
Sorry.
on the bill.
Okay,
I would have yelled your name.
okay, thank you. See, I saw the light. All right, so, so on the bill, can someone move it?
Move the bills amended.
The bill has been moved and second. Any question or discussion on the bill? First was Vice Chair Collison and then Delegate Kipke.
Thank you, Madam Chair. I was asked yesterday by one of our colleagues whether or not setting a floor by which the amount of debt is reduced to be standardized across all hospitals was going to affect their global budgeting and affect their the amount of uncompensated care. I did contact HSCRC, the person who knows the most about the numbers, and she said there would be no impact. And in fact, it would be continue to be recorded as uncompensated care, which is calculated into their global budget each year. So there's no negative impact to the hospitals to do this.
Thank you. Delegate Kipke.
Thank you, Madam Chair. Just two quick questions. One, I want to be crystal clear about when there's the right to take civil action is removed. So there's a threshold, I believe, but I'm not exactly sure what the threshold is.
Wait for
Are you talking about the amendment?
I think, perhaps.
About the under seal? Because right now, if it's under seal, there's a 12-year statute of limitations, so the amendment would remove that. It would just say, even if it's under seal and it's about the collection of medical debt, there is no statute of limitations.
Okay.
That was that part.
And then the last question is, on page 13, this last, not the amendment number, well, there's two amendment number 3s on here, but the biggest amendment, what is this doing?
So the bill as introduced required a patient to sign the
Right.
financial assistance policy, and this was the hospitals wanted this language that would just be acknowledged receipt instead of requiring a signature.
Got it, thank you.
Thank you for the questions. This is the place to ask them, so I am really grateful. Any other questions? All right. The bill has been moved in second. We have had a discussion. All those in favor say aye. Aye. Any opposition to the bill? Seeing none, it passes. And who does not want to be on the bill? Delegate Shalega, Delegate Chisholm, Delegate Morgan Spirit, no, just kidding. He's actually excused for today, and we miss him. Delegate Riley, all right. Delegate Hutchinson and Delegate Kipke, thank you. So we have next House Bill 334, Delegate Kerr. Universal Newborn Nurse Home Visiting Services, Program Establishment and Insurance Coverage. It came out of the subcommittee favorable with amendment. The analyst is Aaron, and the chair is Bagnell. Aaron.
The bill as introduced would have required MDH to establish a voluntary statewide program to provide universal newborn nurse home visiting services, and would have required insurers, nonprofit health service plans, and HMOs to provide coverage and reimbursement in full for the cost to the provider of delivering these services. The entire bill has been stricken by the amendments, and instead a work group has been created. It's a work group on newborn home visiting services that will compile data from current home visiting for families with newborn families operated in the state and identify service gaps between evidence-based models for nursing home visiting programs and current home visiting programs. It will identify potential funding sources to close the service gaps and identify workforce needs. And this work group would report its findings and recommendations to the General Assembly by December 31st, 2025.
Okay, Delegate Bagnell.
Thank you, Madam Chair. This is the little bill that could. And I want to thank Delegate Hill and Delegate White Holland and Delegate Lopez and our entire subcommittee, because this was a bill that really the subcommittee worked on together. We added a cultural competency piece in subcommittee, and with that, it passed unanimously, so I would move the amendments.
All right, amendments have been moved in second. Any questions or discussion on the amendment? Seeing none, all those in favor say aye. Aye. Any opposition? Seeing none, the bill, can someone move it? The bill has been moved in second. Any question or discussion on the bill as amended? Delegate Szeliga.
Thank you. If I recall, when we had, what was that other bill we had on maternal health? And it was a program that we gave them another year to spend the money.
That was a fund that the HSCRC came and gave testimony, and the reason why they needed another year to spend the money was because it was during COVID, and it took a little while for them to, to get it established. But it's going really well, and it's been doing great things. So we did, I think, did we pass that bill? Yes, we passed that bill already. It's in the Senate.
Whose bill, do you recall the number? If not, who was the sponsor? And then I'll look it up.
Departmental bill.
House Bill 170, I think?
Look
Yeah.
at you.
I never did that.
I'm impressed, like, extra credit.
was right.
So during that hearing, though, I asked the Department of Health if they could tell us how many different programs they have. Obviously, maternal morbidity and, newborn health is important, and we've talked about it year after year. And I still haven't gotten anything back. So I don't know if there's, and everyone's busy, so, but
You're busy, but I can follow up. I'll have Michelle, can you follow up with them, please, and make sure we get that information?
because we've had a number of bills for the same thing.
Yeah.
And then just thought I'd let you know, in the BRFA, they're taking $10 million out of that maternal and child health population health improvement fund and putting it in the general fund. So just FYI, I don't know if it'll pass out of the BRFA, but I'll check and make sure it's not the same thing. But
Okay, thank you. I know that, and thank you for your question, Delegate Szeliga, I appreciate it. We will look into it. I know that we have different bills. For example, this one, it's a program that actually follows the mom, and it's very holistic. There's some others that are, will provide, for example, someone to take their blood pressure. There's just different programs, and the reason is because there's 50 states in the US, right? And our numbers were horrible. And then we went down to 25 in maternal mortality, and now we're 19 still. So it's very complicated, and women are dying, and they die within the first 42 days after giving birth. And there's a reason.
Right.
And that is why you see a lot of different programs, because we still have not been able, despite all the programs, to get on top of it. And then when you look at the rate that Black women died, Black women die at a rate 4 times higher than white women. And it is a problem, especially with also people that are poor as well in the rural area. So I know it seems like we're doing a lot, but we got to come from 19 to, I love to be like top 3. Top 3
Yeah.
will be great.
And I think everyone agrees with you. There's no disagreement on those facts that you've laid out for us a number of times. We all agree with that.
Praying it out because you know what? We're going to keep
Right, I got it, but-
appropriating.
But my
that.
question is, how is this any different than the fund that we just passed House Bill 170 for? It seems like duplication. So for those reasons, I'm voting no. I am not voting yes because I mean, I'm not voting against trying to help newborn maternal morbidity, but I'd like an answer from the health department on how many different programs we have. And I think this is exactly what we did in House Bill 170. So,
Different, and Delegate Wagner, would you like to speak? It's different.
I'd be happy to. And I appreciate the question because I know we've got a lot of programs because we're really trying to drill down on this issue. House Bill 170 spoke to existing very specific programs that were, again, they were targeted, they were strategically targeted to meet the needs of the regions that they were serving. So this is a little bit more of a deeper dive on an evidence-based model and comparing it to what we're already doing in the state. Because again, we are a committee that loves data, and we don't want to be setting up programs for the purpose of setting up programs. So this actually pulled back and created a work group so that we could look at what we're doing, the impact it's having, and this evidence-based model, comparing it to other evidence-based models so that we can be strategic in how we scale up existing programs and on addressing the gaps that still exist.
I appreciate that. I would also mention that this was the bonus item that the Secretary of Health chose in the AHEAD program. Remember, we had that briefing, and 7 items, I need you, Aaron, 7 items they admitted to or agreed to, and they got to pick a bonus item, and it was this very thing. So we're duplicating efforts here as well. So again, I appreciate that we've got all hands on deck, but, too many cooks in the kitchen can also spoil the soup. Thank you.
So this is where I'm going to say, Delegate Szeliga, I love you, but we're going to disagree to disagree. Thank you. Delegate Hutchinson.
Thank you, Madam Chair. Just so I understand this now, so we are at a point where the fiscal note is gone, so there's no money in there.
That's right.
And we're at a work group. Could you just explain again the mission of the work group?
So the work group will study existing programs in the state that are home visiting programs for pregnant women and postpartum women, because we do have several different types of programs in the state. And then the program that is operational in Frederick that was envisioned to go statewide and the bill is introduced is a home visiting program that's more long-term and that uses a nurse. So it'll look at that model versus the existing models, see where there's gaps, see where they could complement each other, make recommendations for funding, and also for how we could ramp up and have the available workforce to make that sort of program statewide, if the work group determines that that's a good idea.
Great, terrific. So then, in regards to Delegate Szeliga's concern, because I was the same way, like it just seems we have so many programs, but it sounded like this work group is going to look at those home-based, not just what this bill was going to do, but other, and make a recommendation.
The concern of the subcommittee, and as Delegate Bagnall said, it was a product of the subcommittee. Like, we already do have some programs, so let's look at them compared to this proposed statewide program and see how they could work together and fit together.
Great, thank you, Madam Chair.
Yep, to try to be more efficient. I think you'll appreciate that, Delegate Szeliga. Anyway, where was I? Did I take a vote on this? No. All those in favor say aye. Aye. Any opposition? Delegate Szeliga. Delegate Riley? Delegate Kipke? Delegate? No, we're on the bill voting. Yeah. Oh, It's okay. You can ask. It's good. It keeps us on task. So let's do it again. Any opposition, will you raise your hand? Delegate Shalega, Delegate Chisholm, Delegate Riley, Delegate Kipke. All right. Who does not want to be on this bill? Raise your hand. Delegate Shalega, Delegate Chisholm, Delegate Riley, Delegate Hutchinson, Delegate Kipke, and Morgan in spirit. I'm just kidding. We love you, Morgan. All right, so let's go on to House Bill 406. Delegate Gazzoni, State Board of Examiners for audiologists, hearing aid dispensers, speech language pathologists, and music therapists, appointment of members in quorum. It was favorable with amendment, and we have Lisa and Rosenberg. Go ahead.
This bill alters the appointment process for members of the State Board of Examiners for audiologists, hearing aid dispensers, speech language pathologists, and music therapists. As introduced, the bill requires the governor to appoint audiologist, hearing aid dispenser, and music therapist members with the advice of the Secretary of Health from a list of names submitted to the Secretary and Governor by the board instead of by specified professional associations. Additionally, the bill as introduced required the board to notify all licensed hearing aid dispensers and music therapists of relevant vacancies for the purpose of soliciting nominations, and clarifies that a quorum of the board is a majority of appointed members of the board. The amendments that you can find on, doesn't have it, on page 18 of your packet. These amendments strike all of the language in the bill except for the provisions related to appointing hearing aid dispenser members.
Okay, so what?
Madam Chair.
It's
this
okay,
was
go ahead.
Unanimous, this amendment to narrow the bill down was unanimous within the committee.
Is there a motion then?
So move the amendment.
It's been moved in second. All those, is there discussion or question on the amendment? All those, Delegate Johnson?
Thank you, Madam Chair.
My pleasure.
With this amendment, does it now not undo the bill we did last year?
Correct.
Okay, all right, thank you.
Okay, any other questions or concerns? All those in favor of the amendment say aye. Any opposition on the bill as amended?
Move the bill as amended.
It's been moved in second. Is there question, discussion on the bill as amended? All those in favor say aye.
Aye.
Any opposition? Seeing none, the bill passes. Is there someone that does not want to be on this bill? Okay. House Bill 420, Delegate Palakovich-Carr, Education and Health, Emergency Use of Epinephrine Alterations.
No, there was two identical bills. So the one bill was withdrawn. This bill was primary in Ways and Means, and HGO was secondary. So, sorry, it didn't go to subcommittee.
Oh, no, it's okay. It doesn't- it
Ways
was
and Means
secondary.
voted on it, so we have, HGO has possession. The bill replaces the term auto-injectable epinephrine with emergency use epinephrine throughout the education, health, general, and health occupations articles, and it renames the emergency use auto-injectable epinephrine program to the emergency use epinephrine program. And the reason for this is because now there are non-injectable forms of epinephrine in existing programs. There's a nasal.
I know, it's interesting, I had this bill originally, and we had it in this committee when we passed it to allow the program. That's why we're a little confused, but we are secondary. Are there any questions on this?
Move the bill.
All right, it's been moved in second?
Second.
Moved in second. Any questions or concerns? Seeing none, all those in favor say aye. Aye. Any opposition? All right, let's move on to House Bill 507, Delegate Kerr, State Contract Prohibited Provisions, favorable, Lindsay and Kerr. Lindsay.
This bill clarifies that the prohibition against including a contract provision that limits the state's ability to recover the cost of a replacement contractor is limited to the state's ability to recover the difference in the cost of a replacement contractor, specifically to perform the services not performed by the original contractor, to the extent that the sum of the amount paid to the replacement contractor and the amount paid to the original contractor exceed the costs provided for in the contract with the original contractor. So essentially that the state doesn't pay more than they were supposed to originally. Further, the bill clarifies that the prohibition against a state contract, including a provision that requires the state to agree to limit the liability for any direct loss to the state for bodily injury, death, or damage to property of the state caused by the negligence, intentional or willful misconduct, fraudulent act, recklessness, or other legally actionable misconduct of a person or a person's employees or agents, applies to real property or tangible personal property. There are no amendments.
All right, Delegate Kerr?
Thank you, Madam Chair. There were no questions in subcommittee. Everyone got a full understanding of this bill from the hearing, so I'll move the bill.
Is it moved in second? And Chisholm was going to volunteer to take it on the floor.
Okay, Chisholm,
Is it moved in second?
you can floor lead
All
this
right.
one.
Any questions or concerns? Seeing none, all those in favor say aye. Aye. Any opposition? All right. Let's move on to House Bill 508, State Procurement Preferences, Blind Industries and Services of Maryland, Packaging and Repackaging. It was favorable. Lindsay and Kerr.
This bill adds packaged and repackaged janitorial products to the list of janitorial products that a prime contractor on a maintenance contract with the state or a state-aided or controlled entity must purchase from Blind Industries and Services of Maryland. There were no amendments.
Delegate Kerr.
Thank you, Madam Chair. There, like the last bill, no need for any further discussion, and Delegate Chisholm would like to move the bill.
Okay, it's been moved in second. Any questions or concern on the bill? All those in favor say aye. Aye. Any opposition? Seeing none, let's move on to House Bill 514, Delegate Hill, Health Occupation State Board of Chiropractic Examiners Revision, favorable with amendment. Lindsay and Rosenberg. Lindsay.
The last bill, I need to be recorded as excused.
Excuse for the last bill. So for House Bill 508, for the record, Delegate Kipke is excused.
Thank you.
My pleasure. So House Bill 514, Lindsay.
This bill makes changes to the State Board of Chiropractic Examiners and the law governing chiropractic licensure, including altering board member appointment methods, expanding disciplinary grounds, and granting the board authority to conduct certain examinations of licensees and inspections, revising licensure qualifications, including changes to educational requirements and board-administered examinations, and replaces the extern license with a preceptorship and authorizes the board to issue temporary licenses. The amendments on page 19 in your packet were adopted in Health Occupation Subcommittee to increase from 15 to 20 the number of chiropractors required to nominate an individual to the board, and make technical and clarifying changes relating to allowable inspections of chiropractors' offices, entities that accredit programs offering instruction in chiropractic, and equivalent national chiropractic testing entities.
Rosenberg.
There was unanimous support for the amendment and then for the bill as amended in the subcommittee.
You want to move the amendments?
So move the amendment.
Is it been moved in second, the amendments? Any questions or discussion on the amendments? Seeing none, all those in favor say aye. Aye. Any opposition to the amendments? Is there a second on the bill as amended? It's been moved in second. Is there a question or concerns on the bill as amended? Seeing none, all those in favor say aye. Aye. Any opposition? Seeing none, the bill passes. And who does not want to be on the bill? All right. And just for our audience and those at home, these bills have been vetted in subcommittee. We have 4 subcommittee, the Public Health Subcommittee, the Insurance Subcommittee, Government Subcommittee, and Health and Occupation Subcommittee. Each subcommittee has 10 members. They discuss it at length. They meet with people, and they vote, and then they bring it to this committee, okay? So you might see us smiling, but they have been vetted very well. Let's move on to House Bill 729, Delegate Rosenberg, Public Health, use of opioid restitution fund and training under the Overdose Response Program. It came out of subcommittee, favorable with amendment. It is Aaron and Bagnall. Aaron.
The bill repeals the explicit delineation of certain authorized uses of the opioid restitution fund and instead specifies that the fund may only be used to provide funds for the purposes specified in settlement agreements and judgments relating to claims by the state against the opioid industry for violations of state law. The bill establishes that these purposes may include addressing racial disparities in access to prevention, harm reduction, treatment, and recovery support services. The bill also alters training on responding to an opioid overdose that MDH may provide under the Overdose Response Program to include emphasizing the restoration of breathing, avoiding withdrawal, and compassionate post overdose support and care. There's an amendment on page 32 that was adopted in Public Health and Minority Health Disparities Subcommittee that is a technical amendment because the bill is introduced only repealed half of the list of specified authorized uses, and the amendment strikes the entire list, which was the intent of the bill as introduced.
All right. Delegate Bagno.
Thank you, Madam Chair. This was simply a modernization. It's a technical amendment. I'm going to go ahead and move this amendment, and then I believe that we have an additional amendment to consider. So move the amendment from the subcommittee.
Okay, so it's been moved and second. Any question or discussion? All right, seeing none on the amendment, all those in favor say aye. Aye. Any opposition? Seeing none on the bill as amended? Oh, I'm sorry.
Page 33, there's another.
Oh, I'm sorry.
That's all right. Thank you,
I am
Madam
on a
Chair.
roll.
Thank you, Madam Chair. I would, I had discussions with one of our members who had a proposal for an amendment, which I think is timely and wise, and so I'm going to turn it over to Delegate Kipke.
Delegate Higbee.
Thank you, Madam Chairman. On page 33 of your packet, there's an amendment that adds addressing socioeconomic disparities in access to prevention, harm reduction, treatment, and recovery support services. This amendment really just seeks to ensure that this population is considered. As you know, many people, you could say, were targeted by some of the unscrupulous practices related to pushing highly addictive opioids. And these include places that are, poorer communities. So I want to make sure that they were included as well. So I move the amendment.
It's been moved and second. Any questions or concerns about this amendment? All right, all those in favor say aye. Aye. Any opposition? Great, and that's a great amendment, Delegate Kipke. The bill has been moved and second. Any questions or discussion? Seeing none, all those in favor say aye. The bill as amended, say aye. Aye. Any opposition? Seeing none, the bill passes. Who does not want to be on the bill? Okay, Delegate Riley? Okay, Delegate Shalega, Delegate Hutchinson. Okay. All right, so let's move on to House Bill 820, Delegate Hill. Health Insurance Utilization Review, Use of Artificial Intelligence, favorable with amendment, Lisa and Collison. Lisa.
The bill requires a carrier, a pharmacy benefits manager, or a private review agent that uses artificial intelligence algorithms or other software tools for utilization review, including working through an entity that uses such tools, to ensure that the tools are used in a specified manner. The bill also alters the information a carrier must currently submit in its quarterly adverse decisions and grievances report to include whether an AI algorithm or other software tool was used in making an adverse decision. There is an amendment on page 34 of your packet, and that amendment clarifies that the use of AI may not result in unfair discrimination.
Delegate Collison.
Thank you, Madam Chair. This is a bill that's going after one of the concerns we have around the use of artificial intelligence in utilization management. And we had a couple of amendments offered. We accepted the one which you have before you unanimously, so I'd move that amendment.
All right, the amendment has been moved. All right, any discussion on the amendment? Any concerns? All those in favor say aye. Aye. Any opposition? Seeing none?
Second.
The bill has been moved and second. Any questions or concerns? Seeing none, all those in favor say aye. Aye. Any opposition? Who does not want to be on the bill? All right, House Bill 848, Health Insurance Adverse Decisions Reporting and Examination. Favorable with amendment, Lisa and Collison. Lisa.
This bill expands the required contents of the quarterly appeals and grievances report each carrier must submit to the insurance commissioner. If the number of adverse decisions issued by a carrier for a type of service has grown by 10% or more in the immediately preceding calendar year, or 25% or more in the immediately preceding 3 years, the carrier must include a description of any changes in medical management contributing to the rise in adverse decisions for the type of service and any other known reasons for the increase. The commissioner may use this information as a basis for an examination of the carrier. There are amendments that start on page 35 in your packet. They require denial and grievance notices to include certain information at the top of the notice and prominent in bold print. They require private review agents to make available a phone number and email address dedicated to utilization review that will be responded to within 2 business days. They require the notice to include a unique identifier rather than a name for a medical director or other employee responsible for an adverse decision. The amendments also require specified information to be reported by zip code and require carriers to report a description of efforts and actions taken to determine the reason for certain increases in adverse decisions.
Delegate Collison.
Thank you, Madam Chair. And as Delegate Bagnell said, we are a committee that likes data, that we want to make informed decisions based on data. And this is informing the Maryland Insurance Administration what data that they should be gathering around adverse decisions in utilization management by insurance companies, and that will help us to make better policy going forward. It also includes a couple of points that many of the advocates were concerned about in terms of how they reach the carrier when they have a concern, because there's been an adverse decision or denial, and how people will know about that denial. So that's why there's a requirement to make it very prominent in the notice of denial how they can appeal. So with that, I would move the amendments which were unanimously accepted in the subcommittee.
All right, the amendments have been moved and second. Any questions or concerns? Seeing none, all those in favor say aye. Aye. Any opposition? Seeing none on the bill. The bill has been moved and second. Any questions or concerns? Seeing none, all those in favor say aye. Aye. Any opposition? All right. Who does not want to be on the bill? All right, House Bill 936, Delegate Shetty, health insurance cancellation and non-renewal of coverage require notice. Favorable with amendment, it was Lisa and Collison.
This bill requires a carrier to send a written notice of cancellation or non-renewal of coverage of a small employer plan by electronic means. The notice must include information on additional health benefit coverage options, including COBRA and the Maryland Health Benefit Exchange. There are amendments on page 42 in your packet, and these amendments strike language requiring notice by certified mail and alter the effective date.
Collison, Vice Chair Collison.
Thank you, Madam Chair. This is a pretty straightforward bill, giving people adequate notice to make arrangements when there's a change in their carrier. I would move the amendment.
The amendments have been moved and second. Any questions or concerns? Seeing none, all those in favor say aye. Aye. Any opposition to the amendment on the bill as amended?
Move the bills.
The bill has been moved and second. Any questions or concerns? Seeing none, all those in favor say aye. Aye. Any opposition? Seeing none, who does not want to be on the bill? All right, House Bill 938, and we have 3 more to go after this. Delegate Stein, hang in there. Continuing care providers, governing bodies membership. It came out favorable with amendment. Lisa and Rosenberg. Lisa.
This bill requires the governing body of a continuing care provider that has only 1 subscriber member to authorize the appointment of an alternate subscriber to serve as a regular member of the governing body if the regular subscriber is unable to fulfill the subscriber's duties. The alternate subscriber may attend all meetings of the governing body and vote only if the regular subscriber is unable to fulfill the subscriber's duties as a regular member. There is an amendment on page 43 of your packet that changes the effective date.
Okay, Vice Chair Collison. Oh, no.
Delegate
Rosenberg, sorry. Delegate
By
Rosenberg.
council, the one amendment to the bill is technical in terms of the effective date. That was unanimous. All action was unanimous on the bill.
So you're going to move the bill?
Move the amendment.
Move the amendment. The amendments have been moved and second. Any questions or concern? Seeing none, of those in favor say aye. Aye. Any opposition? Okay, on the bill, you're going to, go ahead.
Bill as amended.
It's been moved and second. Any questions or concerns on the bill as amended? Seeing none, all those in favor say aye. Aye. Any opposition? Seeing none, who does not want to be on the bill? All right, let's move on to House Bill 939, Maryland Commission for Women with Maryland Collaborative to advance implementation of coverage of over-the-counter birth control. It came out favorable with amendment from the subcommittee. It is Lisa and Kyle and Vice Chair Collison. Lisa.
This bill requires the Maryland Commission for Women to establish the Maryland Collaborative to advance implementation of coverage of over-the-counter birth control. The purpose of the collaborative is to study and make recommendations to advance access to over-the-counter birth control. There's an amendment on page 44 of your packet, and the amendment authorizes the collaborative to consult with professional associations with specified expertise.
Vice Chair Collison.
Thank you, Madam Chair. The amendment in the bill passed unanimously. This is really about studying and making recommendations on the coverage of over-the-counter birth control. I move the amendments.
The amendments have been moved and second. Any questions or concerns on the amendment? Seeing none, all those in favor say aye. Aye. Any opposition? Seeing none on the bill.
Move the bill as amended.
The bill has been moved and second. Any questions or concerns? Seeing none, all those in favor say aye. Aye. Any opposition? Delegate Shilega, Delegate Chisholm, Delegate Riley, Delegate Hutchinson, Delegate Kipke. Thank you. House Bill 1100. Excuse me, who does not want to be on the bill? Delegate Shilega, Delegate Chisholm, Delegate Riley, Delegate Hutchinson, Delegate Kipke. All right. House Bill 1100, Delegate White Holland. Public Health Equity Dashboard, favorable with amendment out of subcommittee. It is Aaron and Bagnall. Aaron.
The bill requires MDH, in collaboration with the Maryland Commission on Health Equity, to develop a clear and easy-to-understand graphic data dashboard that includes age-adjusted health disparity data disaggregated by race, ethnicity, and gender. The data dashboard must include information on health insurance access, cardiovascular disease, chronic disease, mental health and substance use, cancer, HIV/AIDS, sexually transmitted infection, and any other health indicators determined relevant by MDH. There's an amendment on page 45, and this amendment requires the data dashboard to be updated on a quarterly basis as determined by data availability. The bill as introduced would have required the dashboard to be updated every 30 days.
Delegate Bagnall.
Thank you, Madam Chair. This was an amendment that was a consensus amendment with the Department of Health. With that, I'd move the amendment, and I also have an additional amendment to offer. So this is moving the subcommittee amendment.
Second.
The subcommittee amendment has been moved and second. Any questions or concern on that amendment? Seeing none, all those in favor say aye. Aye. Any opposition? Seeing none on the other amendment.
So thank you. Thank you, Madam Chair. We realized after the subcommittee that we had not noticed that it spoke on page 2 to mental health and substance abuse. So this just changes the word abuse to use, which is more accurate and more reflective of the data that we're collecting. With that, I would move the amendment.
Second.
The amendment has been moved and second. An explanation was given. Are there any questions or concerns on that amendment? Seeing none, yes, Delegate Hill.
I don't have the language of the bill in front of me, and so I'm looking at abuse and use, and we're talking about illicit use, or we're just talking about any use?
It's if you look on page 2, and I'll just read it. I'll read it to you for simplicity. Starting on page 1, the data dashboard shall include information regarding the following health indicators: health insurance access, cardiovascular disease, chronic disease, mental health, and substance. It currently says abuse, but it should be substance use. Those are tied together. Cancer, HIV/AIDS, sexually transmitted infections, and any other health indicators determined relevant by the department. The reason for the change is that it would, the substance use disorder is the technical term.
Right. The question I'm asking, so I appreciate that change. I guess I'm asking if that, so we are capturing use, whether it is legitimate, illicit, or otherwise. So people are using substances without it being illicit use and without it being abusive use. And so is use sufficient? And we want, yes, I take it as prescribed, I have no problems with it, no addiction, and we're capturing all that too.
I believe that it is efficient because abuse is not defined. So we don't have a defined definition of abuse, but we do have a defined definition of substance use and mental
I
health.
guess what I'm asking is the purpose of the dashboard to capture all use, and then the dashboard, within the department would determine which use it then hones down on. Am I making sense?
Yes.
You are.
That is the purpose.
Yes.
Okay,
Yeah,
all right, good, thank you.
thank you. Delegate Chisholm.
It's one of those years where I agree with Terry Hill more and more, and it's driving me nuts. I think it's way too broad.
If you find yourself agreeing with Delegate Hill, you're going to find yourself on many work groups because they're going to keep you busy, okay?
I'm just wondering.
Anyway, go ahead.
Should it say substance use disorder?
No, because it would say mental illness and substance use disorder. It's mental health and substance use.
Okay.
Those are just the terms that are used.
Those are just the technical
That are terms of
terms.
art that are recognized as. But I like this. This is great. Okay, any other questions? Oh, yeah, Delegate Shalega.
Right, now I'm totally confused. Can you just quickly tell me again what this is doing?
The whole bill or the term?
Yeah, this
The
health
dashboard?
equity dashboard.
Okay.
I guess this question is for either Aaron or Bagnell. It's collecting data and putting it on a dashboard. And then you're going to see, like, when you go visit your doctor and they're like, do you drink? How many drinks a week do you have? Then they're going to be reporting that to the Department of Health? Because
Delegate Bagnell.
Thank you, Madam Chair. So this is information we're already collecting.
Right.
This is just creating the dashboard that is easy to read, that is age-adjusted, looking at the disaggregated data, so that we can see and address any health disparities.
So
This is with the Department of Health in collaboration with the Commission on Health Equity. It's creating that health equity data dashboard, which is in collaboration with our health equity framework.
So I guess I'm going back to Delegate Hill's point. Is there a differentiation in this between use and abuse? I mean,
If I may?
thank
Okay.
you.
All right, if we look at the other criteria, the dashboard shall include information regarding health insurance access. Some have it, some don't. Cardiovascular disease, some have it, some don't. What is the nature of it? Chronic disease, some have it, some don't. What is the nature of it? Mental health and substance use, some use it, some don't. Is it abusive? Is it not abusive? Is it overdone? So I think it gives, you're capturing the information, and then you're looking at what's the characteristic of it, so that's why it makes more sense to call it use, separate from the parallelism with mental health. I think it was about, we're looking at use and then determining whether within the use there is an abuse component or an illicit use component.
Wow.
This data is currently being collected, and there's some criteria for access to it, and this is just going to put it up on a dashboard.
This is creating an easy-to-use dashboard.
Thank you.
And so we're able to compare apples to apples.
And you're able to see the health of the state
able
and
to
the health
see
of
the
the
health of the
communities,
state.
and you're able to guide yourself as to what policies to put forward based on evidence. Okay. Any other questions or concerns? Okay. On the amendments, all right? All those in favor of the amendment say aye. Aye. Any opposition? On the bill? Move the bill as amended. Second. It's been moved and second. Any questions or concern? All right, seeing none, all those in favor say aye.
Aye.
Any opposition? Yeah, I'm agreeing now. Okay, it's okay. Delegate Shalega, Delegate Chisholm, Delegate Riley, Delegate Kipke, okay? All right. Let's move on to the last bill, right? Oh, no, wait, who does not want to be on it? Delegate Shalega, Delegate Chisholm, Delegate Riley, Delegate Hutchinson, Delegate Kipke. The last bill, we got there. House Bill 1380, Healthcare Facilities, Hospitals, and Freestanding Birthing Centers, Perinatal Care Standards. It came out of the subcommittee favorable with amendment. The analyst is Aaron and the chair, Kurt. Aaron.
The bill requires MDH to adopt regulations establishing minimum perinatal care standards that meet or exceed the Maryland Perinatal System standards for each hospital that provides obstetrical services and also for each birthing center in the state. There are amendments that were adopted in Public Health and Minority Health Disparity Subcommittee that require the department to coordinate with MIMS when adopting the regulations. And it also extends the effective date of the adoption of the regulations to before October 1st, 2026.
Okay, Delegate Kerr.
Madam Chair, the bill and the.
Oh, is it, oh,
I'm sorry, I'm wrong.
okay, it's okay.
Perinatal care.
I don't mind direction, I don't mind it.
But it's the hospital.
Delegate Kerr, it's okay.
Discussed in subcommittee. However, the vote was not unanimous. Nevertheless, the subcommittee does recommend the bill to the full committee, so I move the amendments.
All right. Any questions or concerns on the amendment? Delegate Chisholm.
I was the one that voted against it, not because I had anything totally against the bill, but I wanted to know what the standards were, and nobody even from MHA could tell me what the standards were. I just wanted, I said, you're going to adopt these standards later, but you still haven't written them. How am I supposed to know what they're going to be? I know they got to meet the hospital standards, but could go above. And I was like, well, how do I know what they're going to be? Doesn't mean I'm against the bill. It just means
Yeah, so the standards, I don't have, do you have, we have them.
For the hospitals, they're just, according to MDH, the birthing center standards should basically follow
Mirror
the
them.
hospital.
Yes, and we have them, and they're, I don't have it in front of me, but they were in the record, but the birthing centers don't have them, so it's to be consistent, and they will issue regulations.
Right, which makes sense. Or in addition, so they used that term in there, we could add more to them.
That's right, and what they do when they issue the regulations is that they give people an opportunity to give feedback, right? And they're not gonna be less, they're gonna be more. But the people get to opine and give, and they have a period where they publish them and then people give comment back. So it's hard to determine now what they will be because they'll make those determinations when they issue the regulations. But we know that at a minimum, it will be what is required of the hospitals now.
And I agree. I'm not concerned about the minimum. I was concerned about the addition. So
Right.
can the Maryland Hospital Association then use that as a way to create a more burdensome regulations or standards for freestanding?
That's going to be the regulations that are now for the hospitals, right? These other ones will be for the birthing centers.
Right? Are we going to put an undue burden on the birthing centers and saying you have to meet even a higher standard than what we're asking the hospitals to meet?
I hope not. I think that they will be sensible and they just want some type of rules, right? So that when people use these facilities, there's some type of expectation. All right? And we can always, as a committee, write a letter when we see the regulations, and we can always call the Department of Health Secretary, and we can always talk to them. And if you remind me, we'll do that. Okay? And thank you. Delegate Kipke.
Thank you, Madam Chairman. I support the intent of the bill. In our testimony, we have a letter from the Maryland Catholic Conference expressing concern that the guidance from this group could propose standards to mandate abortion services. And so I certainly wouldn't want a Catholic hospital to be forced to do something like that. So I'll be voting against the bill, but I also have sent a letter to the Attorney General for legal guidance around the subject so that we can all have greater legal clarity around the subject. I mean, obviously, the Catholic Conference has their own lawyers that I assume they consulted with, but I just wanted to raise that as an issue. Thank you.
All right, would you like me to hold it until you get the opinion?
No.
Okay.
Thank you, though.
You're welcome. Are there any other questions or concerns? Seeing none, where were we? Oh, yes.
So we don't have any birthing centers. We used to have one, right? Is this going to make it easier or harder for a birthing center to actually operate?
The hopes is that we will get some birthing centers. And I know that there's one, I believe, in the works. So I know that they don't want to make it harder for them, but there should be some sort of floor, right? Like the hospitals have. And that is the intent of the bill. That is why I put it in. I'm putting it right now on the record. That is the intent, not to make it burdensome. And again, the regulations will be issued, and the department worked with me on the bill. They know what our concerns are. And basically is to have some floor. But my understanding is that there's one in the works. Okay? Thank you. Delegate Bagno.
Thank you, Madam Chair. And I just want to thank Delegate Chisholm for his concerns. And I just wanted to say that, because I put in the bill a couple of years ago when we lost our last birthing center in Anne Arundel County, the last one in the state, that there are also national standards and national accreditation. So I think that we will be able to work with the expertise that is already in existence, that the department will be able to work independently of the hospital standards to make sure that we're meeting standards that are not becoming overly burdensome for setting up birthing centers.
Okay, Delegate Shalega.
I appreciate you putting it on the record that your objective is to help birthing centers, but the language says.
Not to help birthing centers. My objective is not to make it burdensome, but to have some type of floor, right?
Okay, but I think you've exceeded that because the word exceeded is in there. Minimum prenatal care, I'm on handwritten page 48. Minimum prenatal care standards for a freestanding birthing center that meet or exceed. So I'm going to vote against it because I think it should meet. And when you put or exceed, you know, I'm fearful that the regulators will exceed and continue to make it difficult. And I would love to see some birthing centers in Maryland where women can go deliver babies, you know, at these freestanding centers. So
I understand.
thank you.
You're welcome. Thank you for your concern. Delegate Hill.
I think, and this may help, that as I read this, meet or exceed doesn't mean they have to be identical. It means that they have to achieve the same health benefit. So for instance, a birthing center might be required to have a transfer agreement with a hospital. A hospital would not because it's a hospital. But that standard would be considered to meet the standard of hospitals being able to respond to emergency situations. Is that a fair understanding?
Absolutely.
That we're not saying identical standards, but that they have to at least meet
Yep,
the health benefit safety issue.
that's right. And you'll be happy to know that you have the bill on the floor. You do, actually. So glad you got it. Any other questions or concern? Okay, were we on the bill? Right? On the amendments, okay. All those in favor of the amendments say aye. Aye. Any opposition on the bill as amended? Second. Bill has been moved and second. Any questions or concerns? Seeing none, because we discussed it. All those in favor say aye. Aye. Any opposition? Delegate Shalega, Delegate Chisholm, Delegate Riley, Delegate Hutchinson, and Delegate Kipke. Who does not want to be on the bill? Delegate Shalega, Delegate Chisholm, Delegate Riley, Delegate Hutchinson, Delegate Kipke. Thank you. We are done with voting. Huh? Oh, who does not want to? Yeah. Okay, I did it. All right, so just housekeeping. It is 2:06. I did promise you that you will get a few minutes to go to the back and get a quick bite. So can we come back here at 2:20? Can we do that? Excuse me? Yeah, and we're going to take it down. Actually, 2:25. All right, 2:25, we'll be back. For those of you that are waiting, we just need a few minutes to stretch our legs. You understand, right? We're humans, all right? Bring us down.